Hello everyone and welcome to a new video. So we already talked about the penicillin types in the previous video of this series, and we mentioned that we have the original penicillin, the penicillin G, and we have the anti-staph penicillin, the aminopenicillin, and finally the anti-pseudomonal penicillin as the types of penicillin. But now we are going to continue our discussion about penicillin by talking about the pharmacokinetics, the mechanism of action, the antibacterial spectrum, the resistance, the therapeutic uses, the adverse effects, and the drug interactions. And it is also valuable to mention that the penicillin was discovered in the 1928 by Alexander Fleming after his staphylococcal cultures were invaded by something that killed the bacteria. And after research, he found out that the thing that killed the bacteria was the penicillin mold. And after a lot of research, they finally produced the penicillin commercially in the 1942, which was a really great discovery. It changed the way that we approach the infections, and Alexander Fleming received the Nobel Prize in the 1945. So beside that, let's start. Okay, so let's talk about the pharmacokinetics. So let's start with the administration. So administration, we have different routes that we can take the penicillin by. The IV route, example for that would be the penicillin G, which is the original penicillin, is taken only by the IV route. We have also the intramuscular route, which example for that would be the benzathine penicillin G, benzathine penicillin G, and this is also taken only by the intramuscular route. We have the oral route, which a lot of penicillins are taken by, and it's preferred that they are taking 1 hour before or after the food, because food would interact with the penicillin and it makes the absorption of the penicillin less. So it would be preferred 1 hour before or after food. 1 hour before or after. The distribution. So distribution, the molecular weight for the penicillin is around from 300 to 500 according to the type of the penicillin. So 300 to 500 according to the type of penicillin, and it is normally non-ionized, but when it enters the body it becomes ionized. So ionized when it enters the body because of the pH of the body when enter body. And because of it is ionized, when it's enter the body, it can't cross the blood-brain barrier, so can't cross the blood-brain barrier, but it crosses the blood-brain barrier when there is infection, like meningitis, because the infected blood-brain barrier can leak the penicillin through it, and it could be leaked, and it would be therapeutic. It would reach the therapeutic level in the cerebrospinal fluid, and it would kill the infection even if it is given intravenously in the case of meningitis. But it can cross the placental barrier. It can always cross the placental barrier, but it is not teratogenic because the baby does not have the transpeptidase enzyme that the penicillin work on, so it would be non-teratogenic for the fetus. Now regarding excretion, the penicillin is excreted by the kidney in general, except for the naphthalin, which is excreted by the bile. So except naphthalin, which excreted by the bile. We have a drug that is called the probenecid. It is used to treat the gout. It leads to excretion of the uric acid through the urine, but this drug would extend the half-life of the penicillin because it leads to retaining of the penicillin and not excreted and lead to inhibiting of the excretion of the penicillin through the kidney. So probenecid lead to retaining of the penicillin and extension of the half-life. Okay, now let's talk about the mechanism of action of the penicillin. So here we have a gram-positive bacteria, and it has a thick cell wall covering it. And here we have a gram-negative bacteria that has a thin cell wall, but it has an outer membrane that is covering the cell wall. The other name for the cell wall of the bacteria is called the peptidoglycan. So glycan, and it contains a protein and carbohydrate. The glycan unit of the cell wall of the bacteria, they are like that, and they are linked together by cross links. And the cross links are formed by the help of enzyme called the transpeptidase enzyme. Transpeptidase enzyme. And the penicillin works on this enzyme. It leads to inhibiting of this enzyme. And this will lead to the breaking or not formation of the linking or of the links between the glycan units, and this would lead to the destruction of the cell wall and would eventually lead to the lysis of the bacteria by the osmotic pressure that is exerted by the environment. And this would lead to the lysis of the bacteria, which is the death of the bacteria. Penicillin also works in another way. It also works by activating the autolysins. Autolysins used by bacteria only during reproduction. It would lead to the destruction of the cell wall, and it would lead to the reproduction of the bacteria by the binary fission. So the daughter bacteria would go out of the mother cell by the help of the autolysins, by the destruction of the cell wall. But penicillin would activate those autolysins, and this would lead to more destruction of the cell wall and lead to death of the bacteria by the osmotic pressure. Now let's talk about the antibacterial spectrum of the penicillin. So penicillin is active against all types of bacteria. We have every type of penicillin is active, has its own spectrum. So the penicillin G, which is the original penicillin, is active against the gram-positives, including the streptococci, the pneumococci, and the staphylococci, and it is also active the Clostridium perfringens, which causes the gas gangrene. And from the gram-negatives, the penicillin G is active against Tropinema pallidum, which causes syphilis, and it is also active against the gonococci. Gonococci causes gonorrhea. After the penicillin G, we have the anti-staph penicillin. So anti-staph penicillin is active against the MSSA, which is methicillin-sensitive Staphylococcus aureus. Now about the aminopenicillin, which is also called the extended spectrum penicillins. So aminopenicillin, it has the same spectrum as the penicillin G plus. So same as penicillin G plus. It is active against gram-positives, including the Listeria monocytes, which causes enterococcal infections, including the UTIs, the endocarditis, the meningitis, and a lot of different type of infections. The aminopenicillin is also active against gram-negatives, including the salmonella, which causes the typhoid fever, and against the shigella, which causes the dysentery. Now about the anti-pseudomonal penicillins. So anti-pseudomonal, it is active against Pseudomonas, as the name implies, and it is also active against some gram-positives and multiple gram-negatives and anaerobes. It also active against the anaerobes. Now let's talk about resistance. So we have natural resistance in bacteria that lack the cell wall, such as the mycoplasma. So this is naturally resistance to penicillin because it does not have cell wall. We have also acquired type of resistance. So acquired resistance, and that's by the beta-lactamase secreting bacteria. So beta-lactamase secreting bacteria such as the staph and some strains of the Escherichia coli, some strains of the streptococci, the Haemophilus influenza, and the Proteus, and some more bacteria. And we have also acquired resistance by the efflux bumps, which lead to the excretion of the penicillin outside of the bacterial cell, and that is in the Klebsiella pneumonia. So Klebsiella pneumonia bacteria have efflux pumps. The beta-lactamase problem in the bacteria is solved with the sulbactam, by adding sulbactam or tazobactam or clavulanic acid into the penicillin. So we add one of those into the penicillin, we will get the penicillin that is resistant to the beta-lactamase, and those are called the beta-lactamase inhibitors. Beta-lactamase. Now let's talk about the therapeutic uses of the penicillin. It is used obviously to treat bacterial infection, but interestingly enough, it is also used for prophylaxis, specifically the benzathine penicillin. The benzathine penicillin G is used for prophylaxis, and it is the only antibiotic that is used for prophylaxis because of the long half-life of 3 to 4 weeks. So it is used in the prophylaxis of the rheumatic fever, and that's in the children who have recurrent tonsillitis. So recurrent tonsillitis, we give them benzathine penicillin for the prophylaxis against the rheumatic fever. It is also used for the prophylaxis against the endocarditis. Endocarditis, and that's in kids who have congenital heart disease, and it is also used before dental procedures in people who are susceptible to endocarditis. So before dental procedures. That's because the dental procedures lead to the bacteremia because of the teeth having bacteria, and when we do dental procedures, this would lead to the bacteria in the teeth being exposed into the blood vessels. So the bacteria would go into the blood, and this would lead to bacteremia. And if the patient has some abnormality in the heart or the heart valves, this would lead to endocarditis. Now let's talk about the adverse effects or the unwanted effects of the penicillin. We have the first one, and the most famous one is the hypersensitivity. So hypersensitivity reactions, and that would range from a simple skin rash to angioedema. Angioedema is a swelling of the lips and the tongue and around the eyes, so ranging from skin rash to angioedema to anaphylactic shock. Anaphylactic shock is life-threatening and need for emergency treatment with corticosteroids. Also, the hypersensitivity reactions, they might be immediate after minutes of taking the penicillin, which is type 1 hypersensitivity reaction, or may be delayed. That's up to 12 days after taking the penicillin, and those would be type 3 hypersensitivity reactions. The hypersensitivity reactions are more with the IV penicillin, so more if the penicillin given IV. And they could be original, so they already existed in the patient, or they originally existed in the patient, or they could be developed over time. And to know if the patient have hypersensitivity or not, you need to ask in the history. So ask the patient, and if the patient is susceptible, you need to do an intradermally penicillin injection with low dose, and you see how the patient's skin would react to it. And if the reaction is severe, you don't give the patient the penicillin. So you test by intradermal penicillin injection, intradermal penicillin. Also, as an adverse effect, we might have seizures if we give the patient procaine penicillin intrathecally. So procaine penicillin intrathecally might cause seizures. We also might get the interstitial nephritis with the methicillin. So interstitial nephritis with the methicillin. Also, there might be bone marrow depression, and that's with the nafcillin. And we might get hepatotoxicity with the administration of the clavulanic acid. in drugs like co-amoxiclav. So now let's talk about the drug interactions of the penicillin. So as we know, the penicillin is bactericidal, and it works best on the rapidly dividing bacteria or rapidly growing bacteria because it inhibits the cell wall during the division of the bacteria, so it works best on the rapidly dividing bacteria. But if the patient is taking another drug that is bacteriostatic, which arrests the growth of the bacteria, like erythromycin from the macrolides, this would lead to the penicillin losing its effect. Because the bacteria is no longer dividing, this will lead to the penicillin losing its effect. Also, in the drug interactions, we have the anti-pseudomonal penicillins, like the piperacillin, is negatively charged, and if given with a drug that is positively charged, like the gentamicin, in the same syringe, if we mix them in the same syringe, this would lead to they both get deactivated by each other because they have different charge. So it is best to give them separately in separate sites. That would lead to the solution to this problem. And with that, we reach the end of this video. Thank you guys for watching, and see you next time. Peace.